Welcome, everyone, to today's first CodamX from 2022. Woohoo! And it's a very special one, actually. First of all, because we have a very special guest, Victor Buwalda, and we have an interesting topic that actually matters in terms of how we use technologies in solving impactful challenges, right? Today we talk about VR technology and applying it in the case of the treatment of consumers of alcohol abuse, right, or disorder, better said. And there is a very special guest who's Victor Buwalda, who is a psychiatrist and administrative psychiatrist with a passion for development of digitalization in psychiatry, right? You're a co-author and author of multiple articles and books about how technology can be implemented in mental health. He's also has a bunch of other different titles in terms of like he's the president of the American Association of Psychiatrists. I don't like there is a bunch of them. Hopefully you can actually maybe mention some of them yourself, but one thing is for sure, we feel very honored to have you here and to actually share your knowledge with so many years of experience with our students. Victor, take over.
Thank you so much. I have to reveal myself, so I'll take out my mouth cap. And of course, we are now in a COVID times. It's always difficult to understand how we are working together. So we need some distance, 1.5 meters still. We have some boosters, and I have here my alcohol. And the funny thing is, of this alcohol, I'm not going to drink it. I'm not going to use it like this. But I'm not going to use it. And alcohol is the main thing of my talk. So this is the introduction. This recovery, it's about recovery. And I will tell you something about this myself. And this is Manix van Giesbergen, that's the professor in the Breda University of Applied Sciences, and I work with him closely. So this is me. I'm a doctor, a psychiatrist. I have my PhD in outcome monitoring, so that means that you use a lot of measurement instruments, and you go to see what the intervention of the doctors is, and if the outcome is that what you want to have. I'm a psychiatrist and researcher at the Amsterdam Office of Mental Health, here in Amsterdam at the GGD. We have a large taking care of 1 million people, and we have to take care of them if they are not psychiatrically disturbed, if they have houses, and if they're not making a lot of noise for you guys in the city, because sometimes they give a lot of noise and we have to do something about it. Which is really interesting because it's also internationally involved in the International Mental Health Initiative, where I'm also part of. I was a past medical director in a large addiction institute in the south of the Netherlands. I will talk about that a little more. I'm the president of the American Association for Psychiatric Administration and Leadership. I'm a member of an interesting exclusive committee of the Group for Advancement of Psychiatry Committee of Administration and Leadership. There are 200 psychiatrists in the United States, and I'm a Dutch guy, and I'm one of them, so I feel very honored. I'm also a member of the American Association for Technology in Psychiatry, and there you already see the link between technology as well as my leadership position. And there are some other World Psychiatric Association on telemedicine, and I was the past Secretary General in telemedicine in the European Psychiatric Association. But what is it, as a psychiatrist, important? We as psychiatrists think that the psychiatrist should be more a coach to their patients. If one feels depressed, if one feels anxious, or have PTSD or whatever, the psychiatrist should coach them. What is the need for the consumer, the patient or the client, and how can we help them? And as the participants in society are more angry, want to take care of themselves, the psychiatry should be a humble person to stand beside them and say, okay, I will empower you, I will give you the information, and that's a good thing. But what happens? So that's the old thing we have to take care of. So you have the client, and then you have the psychiatrist. But these days, as you know, here in Codam, that's the exclusive school for people, as you guys, are interested in technology and how it works, design, informatics, and whatever, and what else. And I'm busy with that too as a psychiatrist, which is odd. So I think in this era at the moment, we need something together, and we need the technology. So that's what I'm going to talk about, how this triangle can be get together. And if you have some questions, please say so we can take care of that as well. So I'm working on an application where we have an instrument where we can, with a cross-cutting measure from the United States, where we can find out the way how people are at the moment, are they feeling well or feeling sick, and they need a follow-up and they need some psychiatric treatment. I'm also busy with working on an app of virtual reality, and I will talk about that at the moment. See if things work. So this is my team, because you cannot do it alone. And I know from Victoria that you are working together, and that if you have a problem, you will go to the other student and ask, oh, maybe you can help me because I think you are an expert in the field, and maybe you can help me to advance my knowledge to get to the next step. So this is the person I talked about. He's a professor in the Breda University of Applied Sciences, and I work with him for already more than 4 or 5 years. There are medical students, a resident or an intern, but there's also a student, an international student, she will come back later, and she is an Italian student. So from all over the world they come to the bureaus to think about how technology can be used, at this moment for mental health, because that's my field. And a lot of people around, and this is my colleague, she is also a PhD, a very good worker, and she worked with me also a long time, that's Dina Weert. So this is the picture I just showed you. This is, you can find also the text of the Institute, the Nova de Kentron, and the Breda University of Applied Sciences. You can find it on the website, www.myrecovery.com. And this is our neutral and safe environment for the consumers and the patients. I will talk about that later on. So Nova de Kentron, I give you a small picture of the surroundings so that you can understand what steps we made to get the VR system into the treatment program. So Nova de Kentron is the largest addiction center in the south of the Netherlands, Breda, Tilburg, Eindhoven, Den Bosch. They have 750 to 1,000 employees. They have about 800 to 10,000 patients who use who are having a disorder in addiction. So it can be alcohol, it can be GHB, it can be cocaine, it can be methadone, opiates, and so on and so forth. But it also can so there can be also behavioral issues with eating disorders, sexual disorders. You can have them all, and that could all lead to an addiction. The thing is that Nova de Kentron is a large institute. It has 23 locations, which is quite a lot for an institute like this. And we have a patient facility, and important is that we have 3 detoxification clinics, where I'm going to talk more about. We have an outpatient clinical detoxification program. We have heroin clinics, so that the patients go to the clinic and take their heroin on the spot 3 times a day or 2 times a day, and they sniff it in, and they go back home and they can find their regular daily work. And we have some other teams. So what is the challenge? I talked about alcohol, and we know that in the United States, it's about 15 million people have an issue with alcohol use disorder, which is a huge problem. But only 6.7 people do get a proper treatment. I will tell you more about it. So it's 5.1 people have it's taking care of the diseases of the world. It costs a lot of money, and we have to lower down or decrease the amount of money we need for the healthcare. But what struck me most was that if a patient is ill, has an alcohol use disorder, and want to get rid of it, they have to go. I know, is someone who knows about it, what you have to do when you are an alcoholic? You can ask. You can, yeah, that's good. You can go to the AA meetings, but that's far after you are detoxificated. So some people go to the clinic first, and they have go to a detoxification clinic, and they have a 3 weeks program. And after the 3 weeks program, they go home and say, okay, yeah, you can do it yourself. You can go to the AA meeting. So that's good. So they go to the AA meeting. But 50 to 75% of these people in the first year, they will relapse. And that's a huge burden of addiction, because a lot of people, and sometimes we see people 5 times or 6 or 7 times coming to the detoxification clinic, and they didn't learn anything. They are not in control. And what I just told you, we would like to give them their control over their own lives back. And that's what we're talking about. So I have here a case study to make it more look like. I have a mister, he is 45 years old. He used alcohol for 20 years. It was a primary alcohol addiction. So that means that it was a primary substance where he is addicted to. So we see a lot of people who are not only addicted to alcohol, but they're already addicted to cocaine or GHB or amphetamine, and they are using a combination. If I use this one, I feel having an upper, and then I use the other one to have a downer and to get things again under control. But sometimes the people who are using alcohol, using afterwards cocaine, and they go depressed, and they go sometimes very suicidal, and that's a very difficult situation. So this guy is feeling depressed because he uses alcohol, but he also, for his mood, I just told, he uses cocaine, and after sometimes he gets depressed again, and then he gets suicidal ideations, and their psychiatrists are coming in. He is lonely. He had a wife, but as you know, 30% of the marriages is break up, and his wife was not so amused with him, and she left, and it was very difficult for him. He has 3 children, 3 and 5 year old, but he doesn't see the children anymore. So there is a lot of things around the person which makes it very difficult for him to get his life up. His house is reasonably proper. Also, we have to take care of our house, we have to take care of our food. He has no job, and underneath he also has some financial issues. So his life is chaos. So as a psychiatrist, we have some classification. It's called the DSM-5 criteria. And if someone, and I put them here on the sheet, you can read them. If there is a strong wish, if there is no control, if there is a persistent use of alcohol, and if they have unsuccessful attempts to get rid of it, well, then they say someone has an alcohol problem. You see that in the DSM-5 we have some differentiation. A light, we have 3 of the symptoms, moderate to severe, and the severe people we are treating. So I will also say that these issues are also very important for the people, because if they are not having control over this, then it will be an issue. So as you know, some facts, but you are better on this position than I do. We have the Dutch situation as the online situation. I think it's not that long ago. And you see that the internet density of the country is very large. So I think about 90% or even more has internet. And I think you all have a smartphone. Is there someone who has no smartphone? You can raise your finger. No? You can live without a smartphone? You're addicted to your smartphone? Oh, sorry. But you see, a lot of people has a smartphone, and that's the thing we can use. That has some other results. Some facts also, we have some consumers. Consumers these days are plugged in. That means healthcare consumers are increasingly using technology to manage their health, as you know. But also, they have also the rise of the wearables. Has someone some wearables on their wrists? 1, yeah, 2. The others don't use wearables, no? Oh, that's interesting. So you have all a smartphone, but not a wearable. So, but it's going to rise up, and it's from 2018, which means that it's also already it's 2022. It's 4 years later with a COVID times. So I think the percentage are rising. Also, the consumers are willing to share, but who of you would like to share your data of your healthcare with me? Can you raise your hands? I'm a psychiatrist, I'm a doctor, I like my patients, I work together with my patients. But who does want to give the data of the healthcare to the municipality, to the government? Can you raise your hand, please? Oh, 2, 4. Oh, that's interesting. Because you don't know in the Netherlands what happens when you give your data to the municipality, right? Because they can do everything what they want. They can just say, okay, you're from another country, and you get some extra money from us, and we want it back. You know, there's all this stuff. What is going on? So it's not so easy to give your data away. But anyway, there is the figures that the people, the consumers say 90% wants to give the data to their doctor, and 30%, 31% to your as an employee, and 41% to the government. So there is a kind of a mistrust to the government when you compare to the doctors. But I missed that a bit here in this audience, so I'm a little bit disappointed. But anyway, I will go on with my talk. So it means that the healthcare consumers are taking advantage of virtual care as well. And you see there's also a change in the amount of people who are going to use virtual reality in the care. And why? Because the appetite is rising for different activities. It's easy to set up your appointment. So, but is that virtual reality? Well, that's more telehealth. That is one screen to another screen. It's zooming, or it's calling to the doctor, and that is, I think, it's not virtual reality. It's a one-way. Well, you have a connection, but you're not virtual in the room. You know it much better than I do. You can better discuss your health concern with the doctor, 62%, and you can also participate in mental health groups, 52%. And the thing is that these zooming and this material gave a lot of speed to the continuation of working together with your clinician when you are when you have to stay home, because when you're corona positive. If you're corona positive, you may not contact. If you are not corona positive, you have to still have some distance, and you are not vaccinated. You have to overcome these issues. So I also think the advantages that they face is that it's reducing medical costs. So the patient can at home. As a patient, who would like to go to the office of a psychiatrist? Can you please raise your hand? Who is very stressed to go to the office of a psychiatrist? Who is very stressed to go to the office of an internal medicine person? Internal medicine or a family physician? Stomatologist. Are you not afraid of doctors? You're not stressed for doctors? Oh, that's a pity. Because the funny thing is, I talk with the patient, and this patient said, well, they said, do you like to use the Zoom? Or do you want to go to the office of the psychiatrist? Well, he said, or she said, it was a woman, it's better to stay at home and talk with the psychiatrist or the clinicians, because then I feel at home, and I'm urged to say more than I am willing to tell in your office. And we had a Zoom session in the United States where there's also you can come to your physician, you can stay at home and talk with your physician, but you can also go to a kiosk, Jumbo or whatever. You can go to a kiosk and you put on your laptop as a standalone, and you log in, and you are talking with your doctor. Because if you're a young woman, you have kids, or you have trouble in the house, or your mom and dad are not so pleased that you're making such a mess, then it's better to have a safe place where you feel free to talk with your doctor or your psychologist. So that's interesting. There is a division of what consumers want. They also virtual reality gives some accommodating schedule for patients, and you have timely access. So if I want to talk with you guys, I will call you or you call me. So well, I have an issue, I have a relapse in alcohol, and then you call me, and then my assistant will set up an appointment, and you can easily get in without having such a burden of driving on your bike, sweating your butts off, having parking problems to get to the appointment of your doctor. So it's more easy. It's also for the persons, it's also providing quality of care for patients, and the diagnosing is faster. So I think it's not a bad idea to use technology in medicine, especially mental health. You have some other thing that it also benefits for the doctors, because there are 60% less people go to 60% less paperwork. The face time is going up, and the admission rate is going down. You can prevent people going to hospital, so that it's not worthwhile to go for that. And also 75% of the consumers will get their information, because I know you know Google and you know how to find all ways to enhance your quality in technology and to see how it works. So when you see in mental health, this is also old dated, the mental health is that 20% of the mental health has already engaged with technology, with Zooming and so on and so forth, with autism, depression, ADHD, and anxiety. And also, you don't see it, but also is the addiction we were talking about. Also important, but you know it as yourself, you want to be in power and control over your health record, your health situation, and you want to be empowered. When I started as a doctor, they adored me as a kind of a statue of, well, you are a doctor, you have to tell me what to do. And now if I tell the people what to do, they say, no, doctor, I want you to help me to think what way I have to go. So there is a paradigm shift. So with the technology, you can use the paradigm shifts is helping the patients to get more empowered and to get more responsibility over their own lives back. So, and that started in 2017 in Berlin. We thought, okay, how can we help people relapse less fast? How can we do it? Also important is to know that in treatment, the patients come to you and they have a kind of a personal prevention relapse plan. Do you know what it is? To prevent that the person is going to relapse, to fall back in alcohol issues. So to make it more concrete, if you're in a green situation, you feel okay. Nothing is possible, you feel free, you are happy. But if you're going to use drugs and you fell back and you have so strong negative thoughts and you felt lonely, then you have drugs and you're sitting alone and you are, yeah, it's not an easy situation. And in between there is some form, you go from A to C, and then you have to go through B, fear of losing control over yourself, as it is the alcohol issue. If I feel lonely, alcohol is my best friend. If I go to the bar, if I'm a social drinker, then alcohol is my best friend. There's a lot of, if I'm very anxious for an examination, alcohol is not my best friend. So don't drink alcohol before you go to an exam. So this is what we talk about with the people in the clinic. We thought we have to create a virtual environment for therapy use. We have struggled and we have seen in the literature what is already available. So we think virtual reality can be an added value for the treatment process for alcohol use disorders. This is a cannabis environment. This man is using the cannabis. You can have here a lot of cannabis, and some also, you know that in these days the THC concentration in the cannabis is very high, 39%, and it was 9% in the old days. But you can get psychotic with the cannabis, and when you have a cannabidiol, you have something which prevents for a psychosis. So be aware. This man has used some cocaine. He has just hit a rock, sitting there. Not a nice situation. It is. Dear students. Students have a nice party, social drinkers. I know that students using also alcohol, but with that also some drugs as well, and they use also GHB, and they don't know what happened, and then you don't know what was going to happen. And in Amsterdam, there are a lot of people who are making disadvantage of those who are using GHB because they don't know anything anymore. And we thought of using, how can we bring technology into our treatment? And how many people do have a Samsung? Samsung? Yes. How many do you have an iPhone? And the other ones, what is there more different? Sorry? Oh, yeah. Okay. But the Samsung had a wonderful idea of making it very easy to use the smartphone for virtual reality. It was high quality, it's affordable, it's easy to use, it's personalized, and you can collect your data. So this was a real good thing, because if also the patients are willing to buy a Samsung, I'm not a sales manager, a Samsung, then they can use it for virtual reality. So we worked with the Samsung, and we made some we create some storylines, and we created animated worlds and also 360. So we used the virtual reality in the computer generated world, and we also used the 360 photography. And then we had also a group in a safe environment, consumers, some therapists, and we have to make some associations. What do you think is needed for the patient? So here are the environments. This is the clinic. That was my former clinic. It's a safe environment. If you are there, then you know if you are addicted to alcohol, you cannot drink alcohol in that building because then you are thrown out. So you don't do it, right? So there is a border, you cannot drink there. This is Orlando, if I'm right, a street with a lot of interesting bars and cafes, and you go there and you have the nice music, and then you feel happy, and then I can take a drink. So this is some stimulation for the alcohol use disorder patient. But when I use cocaine and I see this money machine, I think they're all taken out because of the plofkraag or whatever it's called. So they're not anymore there. But if I was a cocaine addicted and I got my fee for the month, it was burning into my pockets, and I went, okay, I will go and get my money, and then I will go to my dealer to have some cocaine. So this money machine was a trigger for those who were interested in. So it's a trigger. Here's one of the girls who is a social drinker, and this is a lonely apartment. You can imagine that I'm an old man, and that I'm sitting in my apartment, or the man we talked about, his wife is gone. It's a neat apartment, right? And nice television, and you have nice books. It's quite proper. But the one I told you about is not so proper. So if I'm sitting here alone in this world, and I get all these text messages, you don't go for a vaccination. We go to the museum plan to have a strike because we're going to fight for it. We drink a beer, and so this guy is feeling quite lonely. So there's also a trigger. If my wife is gone and my children are gone and they don't want to talk with me anymore, then I have an issue. And then when I sit here in my house, I have a drink. And you will see it later on that sometimes it will be a very messy apartment. And this is also a nice place. How many people think it's a nice place to be? Okay. And do you associate it with alcohol or not? How many do it associate with alcohol? So there's one who is just a little confused what he's going to do. But that's an important thing, because this looks like it's a really nice place, a relaxing place. If I go, because the thing is that we would like to trigger the people to these environments and trigger them that far that if they go there, if it's too much and they go too excited or too triggered, they have to go to this one. But some people say, oh, well, here in the middle there I see a can of beer. and that triggers me. So it's not always a relaxation environment. So we have to think of the relaxation environment of this can be not for the patient, that patient I just mentioned. So that's the thing, that's the few environments, okay, and we would love to have it in computer generated as well as in 360. And we have a creation session, intense program, we analyze the data, and we want to work with consumers. If we are going to make something with virtual reality, put your glasses on. So the thing is, as a psychiatrist, how can you bring technology in the treatment program? So first, I will tell you a bit about, we did some studies. I will go over it a bit quicker. And this study is which environmental cues may form a trigger for relapse in alcohol use patients who just completed clinical detoxification. If I know the environments they are triggered for, then I can help them with the cue exposure therapy to help them to get a better bypass and not relapse. Here's some literature. They did some exposure therapy, cue exposure therapy, so that is you give someone, you trigger someone. If you have a spider phobia, you put your spider so that you are triggered and that you get anxiety. So, but there was the results of all the studies, there were 13, were not that, they were ambiguous. So there were no positive ones and no negative ones. So if that's not, if there is no negative or positive, maybe we have to change it that way so that we can use it and just go to the next stage. I told you we have 3 clinics. 50% of the people use alcohol. And that's why I thought, because we have less finances, the patients are digital self-made, and we do not have to commute. It's the only one probably in Dutch. Sorry. So we thought this high-risk situation for relapse or alcohol dependence is based on the self-reported craving and self-efficacy. This self-reported craving list and the self-efficacy are important because that are the measures to measure someone is feeling well or bad. And this is a medical student. So that's already told you about. And who knows about Marla? Marla is a professor in the United States, and or in United Kingdom, I don't know where he's from. And he was an expert in the cognitive behavioral therapy for a relapse. So he had this relapse model. If I'm an alcohol addict and I'm an alcohol patient. If I'm not an alcohol patient and there is a high risk situation, I'm stressed. My wife is kicking me, my kids are gone and I don't know what to do, but I have to control myself. So I have an effective coping response. I will increase my self-efficacy, I will control myself, and then the probability is of the degrees of the relapse. I will not fall back into alcohol consumption if I have control of myself. That's the good part. But the bad, some people who are having an alcohol use disorder have an ineffective coping. They have it learned on the wrong side of the ocean. They decrease their self-esteem. The self-efficacy is lowering, and at the end, there will increase the possibility of relapse. It is too much in detail, I guess. Benita can talk with you about more if it's needed. But important of this concept is there are some intrapersonal determinants. Self-efficacy, have I control over myself, is the belief that someone can successfully execute behaviors needed to produce a desired outcome. I do not want to fall back in alcohol. That's why I want to get, I'm in control. And the craving is the uncontrollable desire to drink. So these two, yes, please.
And then where the R is actually an added value towards self-efficacy or prevent, like the craving part, like where the technology plays a role.
So this is a great question. I will come back to that in a minute. We have this craving level and the level of self-efficacy. But we have to understand when the graving level is high, and how can I diminish it? And when is the level of self-control good, or I have to increase it? So here's the result. So if I have more graving, the higher the score, the more graving I have, the lower the score of the self-efficacy, the less control I have of myself. So when I am with a friend in a bar, I will fall back easily. When I have a break on Codam, I will not fall easily back. So that means that it is a safe environment not to drink alcohol. When I walk and pass a bar, I have no intention to drink. So there are some cues that say that a person will not fall back in his alcohol use. So there are 3 high situations when I'm with a friend, I go out with a party, already alcohol, and there are some of that I'm not, low situation that I will not fall back. So this was important because it's important that we know that some environments will stimulate people not to drink alcohol or to drink alcohol, but it's also a social aspect. If you're not there, then I will not drink. Then the environment doesn't make some sense. But if you're there and you offer me a beer, then it will be very important for me. Oh, then I will drink with you a beer, and I will fall back, and I will have a relapse. So that's important to know about. So this is the second study, and it's a bit on Victoria's question. How does virtual reality come in, right? So also the student, Clara Obermeier, she did the work. And I'm not sure, but there's also some psychology, the positive technology framework. If you would like to use virtual reality, you have to know that people are using it for fun. And also people are using it for learning something, because you want to learn the person in alcohol relapse phase to learn to cope with their bad situation. And we need to know, if I have this virtual reality app, will it be interesting for me or for you guys to use it? And it's maybe boring for so long study to when is the virtual reality now getting in. It's important to know, because if you are going to program a virtual reality app, that means it costs a lot of money. Thousands, hundreds of thousands to get it done, and you know all this gamification, all these games which a lot of money is putting in, and a lot of people are addicted to these games. Because they have a perceived usefulness, and they have a behavioral intention to use it. Because if there is no behavioral intention to use it, nobody is going to use my app. So I'm not sure. Do you know the model of David, the technology acceptance model? Because this is important, because if this doesn't work, then you can put your app in the garbage bag and you lose all your money. And you know, I only can spend a dollar for one day, and then it's over. If I didn't spend it well, then I have an issue. So what we did, and then you have here to combine it, perceived ease of use, and you have to have some fun, and you have to learn of it as well. So what did we do? I talked about that we have 3 kinds of environments: a neutral and safe environment. This is the clinic, and you have here a menu. So the therapist is Victoria, and I'm the patient. I have this, my glasses on. It's not a Samsung, but it's now Oculus something. You know more about it than I do. Or I have a Facebook account, and I have to use my Facebook account, so that doesn't. And then Zuckerberg is using my data, which I do not want, and then he will take it off. So Victoria is the therapist, and I'm the consumer. And I said, okay, I'm walking here in the clinic of Novo de Kentron and Breda, and it's really peaceful. I don't feel any trigger. And here is because it's a kind of situation. We had a forest, and the people of the Breda University of Applied Sciences made a lot of mountains, because it has to be a realistic environment in the Netherlands. Who think it's a really realistic environment in the Netherlands? Can raise your hand, please. Nobody. Oh, that's too bad. So this is a no-goer. But that was because the British University of Applied Sciences does a lot of virtual work, and there were probably Italian people or Austrian people that said, well, I need a nice environment, I need some mountains to ski off, and so on. This is an apartment of one of the employees, and it is a neat apartment. And you see here some computer, and you see a bar. These are the three environments we took care of, because we want to make a kind of I don't know what it is, that we make a situation, a virtual possibility environment for the consumer, because you have another environment than I do, and you have another environment than I do. So I have to take care of what you are vulnerable for and how I can help you in this vulnerability so that is the challenge. So we had these, and we had these. This is a bar. This is also the department of the employee. We just throw him a bit out and we make it a bit messy. You can see that it's messy, but it should be messy. And you have a forest. Well, the forest is difficult to find a way of. But these are, we show them for the consumers. And these are this is a bar. It's a kind of a old-fashioned bar. Because who wants to go to this bar? Oh, that's not too many, but it's more than I expected. Because this is a bar for people who are 60 or 70 years of age. I do not want to offend you, but.
Like, you know, here you will get the good beer here.
Oh, okay. Oh, that's good, because we are doing research to see if this bar is really interesting for all the people. And this is how it will look like. I don't have and also it's with the Samsung. It was. So to get back, to put this on in the Samsung, we have this clinical detoxification program. We have the somatical withdrawals and detoxification, the mental detoxification, and the recovery and repairing, so for you go home. And the idea was, if you are really alcohol addicted, you have to shake it out the first week. You have a lot of somatical issues. Then you have to mentally get back with your feet on the floor, and then when you get used to it, then you go to the next level and say, okay, now I have more space, and maybe here we try to do our research on the virtual reality. We learned, because we still are we're not practicing, which we are dry practicing. It was important because the satisfaction, we had 14 people. There were 6 patients, ex-patients. There are 5 therapists and 2 nurses. And it was interesting because they know a lot about it. And they said, well, this is interesting. And we give it a satisfaction quote of 8.2. That's not bad. And the thing is that they enjoyed it and they'll learn something from it. So that's an urge to go to the next step. So here's a conclusion. In the first time, the patients can differentiate triggers for relapse in environmental as well as socially. VR seems promising. Patients and former patients are very positive about it and want to work with it. And there is no side effect because sometimes you get dizzy. I'm not sure if you know it, but you can be dizzy and then you have this kind of a dizziness you do not want to have. And there is some positive support of the patient to empower them. Well, this is the last study. To bother you again, this is the research aim. So we had all these studies. We have the study is that how to use it. Also, what we used in the past, we used it to have 3 groups of patients. One who has a technology, a treatment as usual program for the one with the virtual reality, but the computer generated, and one with the virtual reality, but it was with the 360. We used also some instruments, and we also want to know about the self-efficacy and also about the graving. And we did the intervention, and we got some results out of it. The groups did not differentiate much, but the most important one is we also thought, is there a difference between computer-generated world and the 360? And it was for this group, the groups were too small, but you can use them both. Here you see that the satisfaction rate was 7.4, and because of our patients, so that means that it's also good use, and we have advanced it because I think still that the environments are not realistic enough. The intention, the graving was decreasing after the 3 sessions we gave. The withdrawal symptoms were decreasing, and self-efficacy of the computer-generated world and the 360 was improving. So the conclusion is that it has potential, and we are now with the next steps. That's my talk, guys. Maybe you have some questions, or you aren't just.
Can we give a round? Thank you so much, Victor, for the talk and that facts. Literally, like, you took us for a journey from, the usage even of technology and how efficiency technology is towards, different, let's say, data sharing even, and so on and so forth, and getting us towards the VR and how can the VR actually alleviate, specific cravings or self-efficacies, right? For now, actually, I would like to open the floor for some questions, because I bet even though you brought in the facts, I'm curious if our students are convinced about it. Let's see if they have maybe clarifying questions or, I would like to open the floor for discussions, basically. Okay, who wants to be the first one? Oh, wow, that's a lot. Give me a second. Start from here. I would like to mention the people that are following us from home. Please write your questions into the chat of the YouTube live stream, and I will read them out loud. Okay, I'm done.
My question is the people that signed or were basically studied in the study with the self-efficacy thing. Did they sign up for that themselves, or did you ask them to be part of it? Because that might result in some.
Yeah, it's a good question. What I did mention, because of the time and not to make it too boring, is that we did go to the mathematical board. So that means that we have to make an informed consent to those who we would like to ask to participate in the study. So we asked the participants in the second week of the detoxification process. We asked them if they would like to participate in this study. We gave them the informed consent, and they could have 7 days to think it over. And after the 7 days, we asked, are you still convinced to come to participate in the study? And if they said yes, we included them. So we did it with 3 clinics, and they were all, some did not participate, and other did really wanted to participate.
So there was, I mean, imagining there was also a study that did not have the VR stuff involved, basically. Are the results any different between any people that try to get out of a alcohol addiction? That's the word. An alcohol addiction. Were there any different results in between people that did use the VR recovery stuff or did not do it?
Yeah, the group who did use the VR was more able to control themselves, had less craving because we did 3 sessions, in the first, the fourth, and the 7th day, and we measured the craving before the session and after the session, before and after, and we interviewed them for the intention to use. So that means that we had overall the people who used the virtual reality have a better self-efficacy and less craving, and they were quite enjoyable to use it. But the thing is, it's an inpatient clinic study. The idea is to let them go home and follow them a year after they go home and to see if they will relapse more frequent or less frequent. And we think that we can work through the menu to make them more an exposure therapy, because this is quite, so to speak, minimalistic, but we want to use also augmented reality, and we are now in another stage that we use avatars, and this avatar is would you like a drink? So he's offering someone a drink, and the consumers, that's we are dealing with at the moment, they can see, we ask them, if you see such a person, are you triggered by the person or not? Do you want to have alcohol or not? Or do you want to have something stronger? Do you have a beer or a wine? Or said, well, no, I'm not going to use alcohol. So that means that we are now learning to make it more practical, usable for the consumers who are coming next with avatars.
Thank you.
Question?
I think you kind of answered the question I was going to ask a little bit there, but I was wondering between, in the 3 different environments that you had an apartment set up, and I really wondered what the difference is between people's cravings in these kinds of environments in a generic apartment versus their own apartment, because it seems to me that if you have an addiction problem, then your own house would be a lot more triggering than somebody else's environment.
Well, that's a good question too. The funny thing is that you are totally right what you're asking. And the thing is that we want to seamlessly film into the person's life. But it is very difficult. It's very difficult to make a house and a boat and a clinic and whatever. So we start this is an apartment which is already more messy. And this is computer generated. I say that is a Walt Disney version anyway, but it also can trigger. But it's the consumers say, well, this is still not triggering enough. But if I'm sitting in an environment in a clinic, then I feel safe. So do you have some cravings? Well, they say no. But if I'm sitting at home and I will put on the glasses on, then I probably feel more triggers for alcohol than when I'm in a safe environment. So and also the therapists were quite afraid if I put also, because first you have to know the story about a relapse prevention plan. What is your trigger? When are you vulnerable? What is it, your wife you're talking to because you fight all day, or is it your kid who is or is it your job, or what is it that it triggers you so that it makes you more vulnerable? And also this is the beer bottle, but it's not realistic enough. So it should be more with a buckle of Grols or a sticker of the Heineken or a Geneva Granienever, you put it on so that it is more realistic. And the more realistic it is, the more they will become triggered. But for an exposure therapy, it's interesting because you start with the less triggering situation and you talk about it. So what is your trigger? And then you talk about it and they say, okay, this is your trigger. So the next time we will give you another environment with an avatar that gives you what we talked about, the special beer you want or the special wine you want, or so that it is more triggering. And also we with the avatars we are busy because you know that it's how you can recognize your face. And they said, well, we put all avatars in as 20, and they say, well, there's a one with the skirt like an Austrian waitress. Well, nobody is going to trigger here in the Netherlands if you see an Austrian waitress offering you a beer or whatever. So that doesn't make any sense. And there is no mimic as well. So you have to, and now we're also busy with volumetrics to get the augmented reality in the environment of the patient, and to see, because they are more realistic, and they see the more the expression of the face, and hopefully they look like one of the nearest person they know. And if there is a close person who is offering a glass of beer as it's normally do, then they feel much more triggered. You see all this environment of the bar you still like, so that was good, is that the bar was the most triggering because it was very realistic pictures of the bar. But you can turn around, you can walk, but in the 360 you cannot. But still, is it, well, if I see that person on the end, I want to talk to that person. If I could, and if that person would have given me some alcohol, then I would drink the alcohol. So it's also environment, but also the social environment of it. And there are sneaky drinkers. They said, well, I have this relaxed, beautiful Italian landscape, I'm sitting on a couch, on a bank, and I'm thinking and thinking and thinking, and then because I'm thinking I need a beer or something to drink. That's a sneaky drinker. I don't know what it is, sneaky drinker. And you have this social drinker. So well, I go to a bar, I socialize a lot with people, and with the socialization, it's very easy to give me a drink, and I drink it, and I fell back. So it's typical for every person what to do, but you need a kind of a tremendous surroundings environments for those to trigger. There was one issue with this environment is that in this here in this you can see still this one there was a cigarette, an ashtray, and the cigarette was blossoming, and there was a patient said, well, that triggers me most. That triggers me most because I'm sometimes it was a habit. You come home, you work, and you are tired. You're going to sit in your chair. There's a football. You're going to watch the movie, your football game, and you take a cigarette, and you drink a beer. And you have to change that, and that's for everybody. It's different.
Right. With regards to those triggers, do you use mainly people's own data? So do they give you the data with regards to what triggers them, or do you use any methods of trying to identify?
We try to make it more as general as possible. So the bar environment and the home environment would be much easier, but also the house. We had also a house, but yeah, you have. So we are trying to make a bigger collection so that you can be more zooming into the desires of the patients and the therapy for the patient to make it as realistic as possible and to make it as fit as possible. Which is a challenge because you have budget, and we had a 40 grand for an extra step, and then we make the next step with good avatars, and you can do it sometime, and then you can do a small part. So maybe I have to go to crowdfunding to get $1 million or $2 million, and then you said, okay, I have some students here around, and they can all join me, and then we go and find ways to make it real happen. But for you, it's different than for you and for you.
Yeah.
Yes, please.
So I was wondering if so currently it's only going to be used in a clinic setting, right? And I was wondering if it will also be possible to expand to, well, before that, so that someone can use it on their own before they have to check into a clinic or a therapist.
That time, I didn't like so much that the Samsung doesn't do anything with virtual reality anymore, because the Samsung you can use it for everybody could use it, and you could put an app on it, and you can go home and you can just put it on your nose and be in the environment. So there was my passion is to get it to the people and to learn to use it when they are vulnerable. And then you have some peer groups as AA, you have the AA, and then you have your peers who are coming together regularly. And if they use also this system, they can say, okay, Pete, you are just having a bad day. I need I have a bad day. Could you help me, please? And you put both the glasses on, and you're both in the same room, and you can help one another. Well, that's empowerment of the people. But now it's with the Oculus or the other one. It's Chinese, so we may not use the Chinese anymore. But yeah, with Facebook, they want to use your account and then your data. So that's also not. So in Europe, we have to find a way where we can make our own system. And I would love to organize that system with glasses which are less expensive, which are usable for everybody, and who can be used when you're home. But now we are in the clinical stage, and I totally agree. You have to go in an environment, and AA clubs can use it as well.
Yes, so this is in tobacco. There are several prevention techniques to prevent tobacco use. So that these include like tax increase on the plain packaging, that kind of stuff.
if you implement that with alcohol as well, will that also prevent consumption of alcohol and therefore alcohol addiction indirectly?
Also a good question. Well, bad pictures don't scare alcohol consumers away. The thing is, when you are a chronic alcohol user, then there is you lose in the brain, you lose the control function. You are going to experience that you have to use the drug, you have to use it regularly, you have to use it more regular. Your peers say, hey, what are you doing? You are using the alcohol or the drug too many times. You are changing your behavior. You will lose at the end your peers and the people, your loved ones. And you are getting, your life is more and more controlled by the alcohol. Like cocaine users, they see everywhere, they see this aluminum foil papers. And they are so trained to look everywhere, oh, you have an aluminum buckle, so that could be trick me for cocaine use. So it's so internalized in your system. That's such a dreadful tobacco picture, but then for alcoholics, it doesn't make any sense. If you go to a place with Heineken, this picture, then well, alcohol has a longer history than tobacco, or it's slower, or I don't know, but the more people are using, well, that's not true, but we are more oriented or motivated to get rid of the tobacco than the alcohol. So first we will get an alcohol-free environment for our kids, and maybe thereafter you have to say, okay, we have now this alcohol with the 0%, 0, and then, but that also tastes good. The funny thing is that I learned from one of the consumers, he was sober, and there was a party, and it was Christmas time, or not a party, but Christmas, and he invited his girlfriend, and they were all, well, didn't drink for a long time. So okay, maybe now we use some alcohol, but the 0%. And they used 0% and the girlfriend just relapsed and the other one didn't. So it's a stepwise to, oh, if I can do this, then I can control myself when I use alcohol. But that's not it. So you have to say, I will never drink alcohol again. But it's what I want to say with it, I forgot my track, but it's, maybe there will be a time if you're going to fight for it, with the 30 years, the alcohol, we will not drink alcohol anymore. Yeah, tobacco is the thing is, when you have control over yourself, it's not an issue. But when you do not have control over yourself, then it's an issue. And a lot of people who are using alcohol have control over themselves, and you can say, I can quit for a month, no problem. How many people here are using cigarettes still? Only one in the room. Oh. How many people are using alcohol? Do you think it would be a great idea to have an alcohol-free society? How many do not? And why don't you want an alcohol-free society? Once in a while. But do you have control over yourself? Yes. And you? Yeah, I think it's the same question as asking if you want a free drug society. What is alcohol? How? Yeah, how many people have control over alcohol use? Is a little hesitant. Can you raise your hand a little more higher? Okay, that's better. How many people do not have control over their alcohol use? Do not. Okay, then you come up. I will. find a possibility to treat you, but well, it's more engaged in society, and the thing is that for alcohol, children may not drink alcohol. With cigarettes, yeah, youngsters are drinking alcohol because well, it's not true as well. But it's a good question, and it's give me a chance to think. But it's up to society if they wanted to. If there is a foundation, a basis to get rid of all the alcohol, yeah, you can start the process. Alcohol out of the world. No, that's yeah. I'm not sponsored by alcohol company.
Just looking at the time, I'm aware that some of you might have trains or trams to catch. I would like to wrap off and give a big thank you to Victor. Can we give a round of applause? I am personally fascinated by the different applications of technology, and especially into the topics that matter. Okay, many of you come to me and ask me for an internship in a company, be it a project, that is impactful. Okay. Me and Victor, we were talking earlier about maybe we could do an internship opportunity to work on this project. There is nothing yet on paper, but if there is anybody from our community, from here, from back home, that is interested in doing an internship on the topic, please just write me a line, okay? And then we will talk also with Victor later on, and we will see what we can actually formalize, if we will actually formalize as well. Yeah. Yes. And one more thing before we split up. I want to give a warm welcome to the students from Student Experience. We have a couple of ladies over there. So from now on, actually, just for you to know, we have Student Experience. It's actually like a housing. Some of you might know because some of you might live over there. And we opened our event towards those students too. So they can join, our events in the auditorium as well as from home. So warm welcome. Hopefully it's not going to be the first and last event, so yeah. Thank you, guys.
And if you have any questions,
Victor,
you
again.
can call me or write me.
Yes, you've got the details over there.
Picture and then you can.